Hello, this is JP Salibi. I will be talking about delivery systems for LDN, for low-dose naltrexone. So sit back and enjoy this lecture. This is intended for all attendees or enrollees in the Priority Health Academy. As far as my disclosures go, I am the director of a nonprofit 501c3 teaching academy called Priority Health Academy. I also am the medical director for the Carolina Holistic Medicine Centers in South Carolina. And as I mentioned before, I sit on the board for the LDN Research Trust. I have nothing else to disclose and no conflict of interest. The objectives with this lecture on delivery systems of LDN will be oral forms of LDN, VLDN, ultra-low dose naltrexone, capsules, tablets, troches, liquids, chewables, and gummies, and readily dissolvable tablets, along with sublingual or buccal mucosal lozenges. However, this will be discussed in greater detail by some of my collaborating physicians at this event. I'll focus mostly on the topical forms, that's both topical and transdermal, and there are subtle differences, as well as the LDN nasal spray and ophthalmic solutions. Finally, wrapping up with injectables, which are rarely used, and then also how to write a professional compounding prescription. The mechanisms of action will be covered in other lectures, so I won't go into a redundancy here, as well as some of the dosing ranges. For standard dosing, and that's for alcohol and opiate abuse, naltrexone in its high dose form is usually between 50 and 100 up to 300 milligrams. Low dose naltrexone usually spans the dosage range of 0.5 to even upwards of 6 or even higher milligrams per day. And again, these are used for things like your autoimmune disorders, fibromyalgia, multiple sclerosis, Crohn's and ulcerative colitis, cancer therapies, Hailey or pemphigus, and also complex pain syndromes, along with immunocompromised patients that you normally see in some of your Lyme and MSID sufferers. Very low dose naltrexone is 0.001 to 1 milligram, and it is used in other pain states and for folks with lower tolerances. And then you have ultra low dose naltrexone, which is a dosing regimen less than 0.001 milligrams per dose, and this helps potentiate opioid analgesia and help get folks off of their opiate therapies. And this slide demonstrates capsules and tablets, troches, liquids, chewables and gummies, or what they call gummy bears, and rapid dissolving tablets, RDTs, and sublingual lozenges. Capsules and tablets are probably the most prescribed. They tend to be very easy to take, cost effective, and well tolerated. You need to have a well-functioning gut as necessary for optimal absorption. It turns out that LDN may help heal leaky gut or intestinal permeability. So it is a win-win situation when this intervention is used in both treating patients with leaky gut or dysbiosis and other autoimmune or cancer, etc. Remember that dysbiosis can affect the absorption of this drug. All right, this is a great slide. I use it often in my lectures about the mechanisms of action of LDN, and this will be covered very nicely by some of the other speakers at this conference, so I'm not going to spend a lot of time on it. But I do want to point out a few things with regards to Lyme patients. I use it for its immune enhancement properties. Also, we should note that it improves inflammation, and that's going to be very important when we discuss some of the things with some of the other delivery systems. And also it does promote DNA synthesis, which is important in tissue healing, whether it's corneal ulcerations. And there's been a number of studies, both animal and human studies, of this, as well as in the gut. So folks with issues with their gut, and it is used to heal and repair mucosal tissue as well, and this is important in our inflammatory bowel disease patients. And then finally, it does regulate Th17, which is very important in autoimmune disease and allergy. Other delivery systems are troches and RDTs and sublingual lozenges. So when tablets or capsules are not tolerated well or impractical, troches may be a helpful delivery system for micro-titrations and micromanagement. The nice thing about those, as opposed to, let's say, a hard lozenge or even a readily dissolved tablet, is that with a troche you can break them apart and titrate them instantly. This is an example of a troche here. It's scored in 4s, quartered, and you can take apart a whole, so it's easily used to titrate, especially when you're accelerating or increasing your dose to try to find the right dosage of LDN. Sublingual or buccal absorbed through the mucous membranes in the form of a lozenge is also an option for those with oropharyngeal dysphagia. And RDTs are another great option for rapidly absorbing this drug if swallowing is difficult, or if we're dealing with a pediatric population where swallowing a pill or even taking a bad tasting liquid is not appealing, or in veterinary applications. And here we have liquids and chewables, or gummies, or gummy bears as they're referred. Liquids and gummy bears are very well suited for the pediatric population, and also those, again, with swallowing difficulties. Some people just cannot tolerate taking a tablet or even a capsule, and also those who have to be administered this drug through a feeding tube. It is a good point when you write for this to ask your compounding pharmacy that all your LDN prescriptions contain no corn, dairy, soy, gluten, casein, or dyes. Especially with those suffering from autoimmune disease and those with leaky gut, some of the big offenders like gluten and dairy can exacerbate their underlying conditions. So it's best not to give them even minuscule doses when you're administering LDN. So just ask your pharmacy, gluten-free, dairy-free on this preparation. A few pearls with LDN dosing. For example, when you're using standard tablet and capsules for the majority of which I write for, which is in that form, LDN usually starting out with 0.5 or 1 milligram as a starting base dose, in which I'll titrate up to about 4.5, 6, or even 6.5 milligram. So you want to make sure that you ensure the excipient base is appropriate for the patient. Lactose, remember, can be problematic with autoimmune patients, such as those suffering from MS, fibromyalgia, and others, and also those with Lyme disease. So make sure you exclude that when you write for this. Capsule size is also important, so be mindful of that with your patient's needs. And also, do not use any modified release formula. It's important the way this works is for immediate release. So do not write this as a sustained release or an extended release, or what we refer to E4M as it should be used. That's the proper nomenclature when you're using sustained release formulas in compounding. I would also recommend, if you're doing a rapid titration, depending on my patients, sometimes I rapidly titrate from 1 milligram to 2 to 3, 3.5, etc. over the course of a 2-week period. So I would normally dispense a volume enough to allow that so that it doesn't necessitate frequent refills. So I'll write 100 capsules of a 1 milligram capsule, and I'll ask the patient to titrate that up. First 2 weeks, you take 1. For the week after that, you take 2 capsules, etc., until you reach the appropriate dose. You can also do that with lower increments. So you can dispense a number of 1 milligram capsules and then ask the pharmacies to dispense a second prescription with 0.5 milligram capsules And this will allow titration from 0.5 to 1 to 1.5 to 2 to 2.5, etc., as needed for each independent patient's titration needs. Once established, you can then have the exact dose per capsule. This actually will save the patient time and money in the long run. Oral dosing suggestions. Initiation of oral doses is very variable, and in this era of precision medicine and personalized medicine, every patient's different. So you sometimes will start, especially my hypothyroid Hashimoto's patients, with 0.5 or even 0.25 milligrams at bedtime. With other folks that are more robust, maybe cancer patients where you want to get the titration up quickly, you start out with 1 milligram capsules at bedtime. You can increase by 0.5 milligrams or 1 milligram in a 1 week, 2 week, 3 week span, depends on the patient. So normal doses usually have a ceiling of around 4.5 milligrams. That's what's been best studied. But there have been cases where one can write for 5 milligrams or 6 or even up to 8 milligrams, depending on what you're trying to achieve. Dosages for depression, alcoholism, gambling, and other addiction disorders are variable and tend to be higher. Titrations do differ. And also dosing. If somebody has sleep intolerance or insomnia because of LDN, the first step I usually do is keep the dose the same, but move it from nighttime dosing to morning dosing, or divide it into 2 and do BID dosing. So there's no set rule. One can look at the research and see that nighttime dosing, because of the mechanisms of action, may work best because of the effects of this drug 6 hours into your sleep, 4 to 6 hours into your sleep, of how it works on some of the receptors. But it can still be an effective drug and therapy if given just in the mornings or in BID dosings. Side effects generally, and I warn my patients about these, are vivid dreams. Not necessarily nightmares, but just kind of vivid, unusual, entertaining dreams. And then there's about maybe less than 10% chance of sleep disturbance. And again, that's easily remedied by either dosage adjustment or timing, chronopharmacology, timing of the taking of the capsule or pill. Other things that people complain of are a little bit of nausea or GI upset. A little bit about oral dosing with regards to pain. So we are using this in chronic pain syndromes, and you have to be mindful that you will want to use it the same way with the same dosing regimen as you will with other diseases. You may want to titrate at 0.5 milligrams until resolution of symptoms. Most will be at around 4.5. Some clinical notes to remember. You must make sure that this drug will induce withdrawal in patients taking opiates actively. So make sure there's a good washout where they stop taking their opiate therapy so that this won't be a problem. It can be quite significant and severe when people go through this withdrawal, and it can be expected to last up to 3 days. Pain control may need to be reestablished with other non-opioid agents such as NSAIDs or some anti-inflammatory drugs like curcumin. And tramadol I've used before, even though that somewhat can be blocked because of its mechanism of action. But tramadol or Ultram is a good choice for someone who needs more of a centrally acting agent, and I would dose it remote from the dosing of the LDN. For example, if you want to dose 50 to 100 milligrams of tramadol in the morning to help with pain relief, then you dose the LDN in the evening, so as far apart as possible. Other non-pharmacological therapies you can prescribe, things like acupuncture, deep tissue massage, meditation, and there are some other things that can help with pain. You can also consider very low dose naltrexone or ultra low dose naltrexone in a BID or twice a day regimen versus just the QHS dosing. So for oral suspension or liquid, we would look at LDN in a 10 milligrams per ml solution, either in an aqueous or an oil base. The naltrexone 100 milligrams per ml as far as transdermal. Now transdermal goes through the skin to be used systemically. Use a 10% formula. You can start much lower if you desire, but remember this is different than topical. Because topical you want to use for regional and transdermal you want to use for more systemic delivery. Once daily dosing is okay, and the difference is with topicals the standard dose is usually 1%. So LDN has another delivery system which is a nasal spray, so it's a nasal application. Compounded in a sterile form by sterile compounders is best, at a concentration of about 1% naltrexone in a buffered solution that is titratable, because you can use a varying amount of actuations for this purpose through the nasal mucosal system. When oral and topical applications are not tolerated or impractical, this is an alternative delivery system that is desirable. The volume per actuation, and it depends on the pharmacy and the type of nasal spray they're using, is actually about somewhere between 50 and 100 microliters. So nasal spray applications, we're looking at a study that was done to compare naltrexone to naloxone, mostly for overdose applications, where they looked at Cmax and time and found that the intranasal naltrexone at 4 milligrams was comparable to those values reported from the FDA-approved 4 milligram dose of intranasal naloxone, or Narcan. Also, there is enhanced absorption when you use DDM, ductylmaldehyde, which actually can increase absorption by threefold, reducing the Tmax from 0.5 to 0.17 of an hour. So despite these very rapid increases in plasma concentrations from naltrexone, its short half-life following intranasal administration, which is about 2.2 hours, may not be very useful in an OD, overdose situation, but conversely, it's very useful in the applications in which we use LDN. So this slide talks about the bioavailability, which I just previously discussed in the previous slide. I'm not going to spend a whole lot of time talking about this, but just reiterate that DDM may be helpful when formulating this for enhanced absorption. My slides at this point sometimes are a little bit text heavy, and this will allow the viewer for this event to pause and read these slides at their leisure for more details. I do note some of the references at the bottom, and there are some further references at the end near the end of this lecture. The applications for using LDN in the form of a nasal spray are useful in management of chronic pain conditions, where you would sometimes also use oral LDN or VLDN or ULDN. Again, it makes titration easier, and it's easily administered. It's used nicely in fibromyalgia, Crohn's disease, ulcerative colitis, MS, complex regional pain syndromes, cancer, Hailey-Hailey disease, which is benign chronic pemphigus, a dermatological disorder, and major depressive disorder, MDD, and other conditions that are enumerated nicely by others at this conference. This slide shows a very detailed breakdown of the constituent parts and ratios of a nasal spray. Now this one is under consideration for a patent for this particular delivery system and application. This is, again, a very detailed slide. I'm not going to read this to you, but if you wish to pause this lecture, you'll have ample time to get into it and read the entirety of it. Nasal spray typically is dosed a little less than the capsules, ranging from 0.5 to 2.5 milligrams per ml. You can use 2 sprays BID to 3 sprays BID. One spray generally delivers 50 to 250 micrograms of naltrexone. Efficacy is very good, especially in those suffering from neurological disorders. Epstein-Barr, Parkinson's, Guillain-Barré are especially responsive to the nasal spray. Take great care when using nasal spray in patient education. The pharmacist can also do this, or you can delegate it to the pharmacist when they pick up their prescription. But the clinician should do some good bit of patient education. It requires this, especially with pediatric patients, teaching the patient and the parents. Sensitive patients and children require smaller doses, and this typically is a very good way to deliver that and titrate that. Let's move on now to topical and transdermal applications. Again, there are some nuances between the two. Transdermal absorption is generally used for more systemic administration. Topical, usually 0.5% to 1% in a cream or gel for regional pain syndromes and dermatological conditions. Transdermal suggests 1% to 3% in a lipoderm cream for more of a systemic. You can go as high as 10% if you wish. It tends to be stable and holds its own up to 180 days when used either ambient temperature or refrigerated. So the topical use is very useful in dermatological conditions such as pruritus, psoriasis, and eczema or atopic dermatitis. And there are some references to its use in research. I'm going to speak briefly about some of the mechanisms of action in the skin where this may not be covered in other lectures. So there is some effect on the inflammatory cytokine IL-6. We see there's significant decrease where the drug is applied to the tissue of Ki-67 protein. And other things like beta-catechinins and cyclin D1, CMYC, and C-Jun, and MET proteins. So there are several pathways that are novel and have just been discovered in the skin that are under the influence of naltrexone. There is a growing body of evidence for evidence-based medicine for the use of naltrexone in skin conditions. So this is nothing new, and it's been fairly well researched with some recent research being published in the last few years. Topical naltrexone has also been used in wound healing and post-operative wound healing. The anti-inflammatory effects may be very helpful in preventing keloid formation and expediting wound healing. In 2020, there was a case study published after a patient had received Mohs micrographic surgery, MMS, for some skin cancer. And they utilized topical naltrexone to enhance wound healing and avoid keloid formation. And this slide actually shows a number of references to the use of topical naltrexone creams or gels in treating the skin as an anti-keloid and an anti-scar treatment. The effects on toll-like receptors expressed in dermal fibroblasts results in hypertrophic scarring, and this, of course, we know from its MOA, has an effect on toll-like receptors. So there was a study by McLaughlin regarding type 1 and type 2 diabetics and stasis ulcers. As we know, folks with diabetes have decreased DNA synthesis in the epithelium, and they're susceptible to not well healing ulcers. Both systemic and topical applications of naltrexone have increased DNA, that's a typo, it should be DNA synthesis, up to 2 times as much. We do know the LDN effect on enkephalins, endorphins, and dynorphins. We also know that opioid use tends to inhibit or modulate in a negative way our immune system and cell proliferation. These 2 studies demonstrate the use of LDN with methionine enkephalin and its inhibitory effects on proliferation of keratinocytes in our skin. So enkephalins do play a role in the differentiation of epidermal keratinocytes. And again, opioid receptors play a big role. You have mu, delta, and kappa opioid receptors. And this study showed that MOR, DOR, and KOR are all linked to regulation, which can cause hypertrophic scars with dysesthesia. So a kind of discomfort in the skin, if you will, that's related to scar tissue. This can be countered with topical or oral low-dose naltrexone. A few things I want to talk about dosing with regards to topical naltrexone in the realm of pain. So when you have a localized topical pain syndrome or regional pain syndrome, and you want to use topical naltrexone, you want to start at 0.5% and apply anywhere from 0.2 to 0.5 mLs once daily at the site initially. Now you can increase that as time goes by. You can use this alone or in combination with other inflammatory conditions and the use of NSAIDs or other oral or topical creams that can be compounded together. It is not recommended that you use this therapy in opioid patients. It is not recommended because of possibility of withdrawals. As far as naltrexone itch cream, you can use it as a standalone 1% or in combination with any of these mentioned here. Permoxin, which is an anesthetic topical, Transilest 1%, which is a synthetic analog of tryptophan that is used as an anti-allergy or anti-inflammatory agent. Aloe vera is great for including this for soothing purposes, and also diphenhydramine 2% as an antihistamine. Caution, sometimes antihistamines topically can cause issues with skin reactions. Wound cream suggestions: you can add naltrexone in any kind of pre-prepared wound gel or cream, or you can add or make your own. So naltrexone 1% cream, let's say, and you can use any of these other agents like phenytoin, aloe, arginine, which actually can help improve blood flow and temperature of the skin. Misoprostol, low doses, is a prostaglandin E1 analog, and that sometimes is helpful in wound creams. When it comes to pain cream suggestions, the sky is the limit, as there's so much we can do in compounding. So 1 to 10% naltrexone cream for more of a systemic application for systemic use of pain. You can also add other agents like diclofenac, baclofen, cyclobenzaprine, tetracaine. Ketamine is sometimes used, and as is gabapentin. So all or some of these in combination can be effective in a topical pain cream. That includes naltrexone. Scar creams between 1 and 3% naltrexone in combination with some antihistamine and some corticosteroids, and doxepin, which is a tricyclic that can help reduce itching, and other agents are helpful in compounding this scar cream. Let's move along to ophthalmic applications and solutions. You want to make sure the compounding pharmacy is well versed in doing steriles and has some experience in ophthalmic solutions of 0.2 to 0.3% concentrations usually. It does appear to work on metaencephalins levels, which are reduced in symptomatic individuals and seem to be restored with the use of low-dose naltrexone eye drops. Topical eye drop treatments of naltrexone normalized tear production and corneal sensitivity. Studies were done in type 1 diabetic rats and another study in rabbits with the same outcome, very good outcome. And folks with dry eye disease, or DED, animal studies were conducted, as well as human trials for efficacy and tolerability. There were also additional studies in dogs. This study in the Journal of Ocular Pharmacology was a human study. The previous ones were animal trials, and this came out of a journal in 2016, showing the tolerability of ocular naltrexone. It was very well tolerated in treatments observed over a week period of time. Of course, the intramuscular injection of naltrexone has been around for quite a while. It might be used better in those with opioid or alcohol addiction problems as a longer-term sustained release type of drug delivery system. It's not got much application, honestly, in those that we write LDN for. However, I did want to mention this is a commercially available naltrexone injection with each vial is a single dose vial of 380 milligrams, but 1 ml will deliver 95 milligrams of a more sustained release naltrexone. When compounding any type of LDN, whether it's tablets, capsules, liquids, gels, creams, or ocular drops, it is very important to find a compounding pharmacy and pharmacist that you are very comfortable with to help you navigate some of the caveats in prescribing this novel application of this drug. Other resources are the United Kingdom's LDN Research Trust and also ldnscience.org. This is a list of some of my references, and also embedded in the slides and also the notes section of my PowerPoint presentation are further elaborated references. And if anyone has any questions regarding this lecture, I will entertain questions by email. You can email me at drsalibi@Carolina Holistic Medicine or through my website, salibi.net. Thank you.